Hi everyone. Before the meeting starts, I'll take the opportunity to very quickly introduce myself because I will switch my camera off once the meeting properly gets underway. I'm Frances West, and I'll be taking over as chair on the 1st of February. And Mark and the team have very kindly invited me to observe today, so I can hit the ground hopefully at a bit more of a trot. But thank you so much for including me, and I'm really looking forward to the day's proceedings.
You're very welcome, Frances, and I'm glad that our time together last week didn't scare you off joining the Trust.
It was incredibly useful, Mark, and reinforced my view that I'm looking forward to it as much as I am.
That's good. Welcome. Well, let's make a start as we've reached the hour of 10 o'clock. Welcome all to this month's Berkshire Healthcare NHS Foundation Trust Board meeting. Happy New Year to all of you who I haven't spoken to already. We have a number of observers with us today, some from the CQC and some from NHS England. Welcome joining us at the meeting. And as I just extend a particularly warm welcome to you, Frances. We look forward to you joining us formally on the 1st of February. I'm informed that we have no public questions for today's meeting. Julie, do we have any apologies for today?
No, we don't, but Paul's having IT issues and he's rebooting his computer.
Okay, Paul will join us then as it does. Do we have any declarations of any other business for today's meeting? No, nodding heads. No. And any declarations of interest, either amendments to the register or for today's agenda items? Okay, shaking heads. Thank you. So we go on to the minutes of the meeting held on the 11th of November. Can I just check that everybody is content in terms of the accuracy, or are there any amendments or adjustments needed to those? No. Take those as accepted. And then the action log, as far as I could see, all of those are in train. Are there any that you feel need further attention? The only one I would highlight, could I just ask Sally, are you content with the update that you received? Because I know you raised a question at the last meeting in terms of unconscious bias. It's contained the response on page 36. Can I just check that you're content with that?
Yes, this does give me some assurance. I raised it a couple of meetings ago, Mark, in relation to it was post Nottingham review in terms of identifying patients who may have a risk around safety to others and non-compliance with antipsychotics, and whether unconscious bias was considered in relation to identifying those patients and possibly community treatment orders. And it's good to see that there's going to be a review in January. You know, it gives me some assurance around the governance around that, and also that the fact that well-made point that it's actually integrated into other ongoing quality improvement initiatives. So yes, I do have some assurance around that in terms of the overview, the governance, and the integration through ongoing quality improvement initiatives.
Thank you, Sally. Take that as approved. Moving on then to this month's board story, which comes from our Learning Disability Service. A warm welcome to Becky and Daisy. Welcome to the meeting. I'm looking forward to receiving your presentation. Debbie, do you want to give an introduction to the session?
I'm just going to hand straight over to Daisy, who's going to take us through this case study with a particular focus on hearing the person's voice, the person with learning disability, and feedback directly from the family around their experience of support from our services.
Thank you.
Lovely. Hello. Right. So I will get on and share. Right. So something should be appearing magically. Can you see?
Yeah, that's there.
Lovely, lovely. Okay, so hello. As said before, my name's Daisy Coates. I'm a learning disability nurse by background and have been for many years, but at the current time, I'm in the process of transitioning into an advanced clinical practice role. I work within the Berkshire Intensive Support Team, and as we said, I wanted to go through a case study for someone I've been working with for a while. Okay, let me just move my mouse. Right, so a little bit about our team. So we're called the Intensive Support Team, or the IST for short, and essentially we're a multidisciplinary team made up of quite a few professionals. We've got some nurses, we've got speech and language therapy, occupational therapy, psychology, amongst others. And essentially we cover the whole of Berkshire. So on one day there is a possibility that we could be working in Hungerford at one point and then sort of close to Slough, London at another point. We offer a 5-day-a-week service with additional on-call, and we've been working now for about 7 years, so we were established in 2017. Largely our remit is to work with adults with a learning disability, and those people that we support will already have an open referral to our other learning disability teams. The reason that they would come to us would be that there's real concerns that the person's behaviours are challenging their services to the extent that people are thinking that they might need to go into hospital, or they're at risk of losing their home or their placement, as well as sort of concerns around that person's quality of life. And so sort of on the converse side, what we're looking to do is reduce the likelihood of hospital admissions, acting as an alternative so that we can reduce those behaviours concern and create a positive change in that person's life. And so by the nature of that, lots of what we do are based within the person's home, and we work with both the individual as well as the sort of the support systems around them. And sometimes we find they need additional support systems, so then we'll be advocating for the provision of those sorts of things. So that's just a whistle-stop tour about our team. But now I'm going to focus on Cecilia's journey. So Cecilia obviously is a pseudonym, but I just wanted to tell you a little bit about her. So really a very complex case, and there's lots of information that it would be very difficult to go through in this 10-minute period. So it's just going to be a quick touch, really. But essentially, she's a young lady who has physical disabilities as well as severe learning disabilities. While she does have some communication, it's such that she's unable to really reliably report past events or experiences, and because of that, she's at risk of being unable to report pain, mistreatment, or situations that cause her emotional distress. Her physical disabilities mean that she is a full-time wheelchair user, and she requires the assistance of 2 people to move her from chair to bed, for example. But overall, she requires 24-hour care and support to meet the full range of her needs, which obviously have to incorporate her physical needs, but also her emotional and social needs. To give a bit of background, so Cecilia she's been well known to the local learning disability teams for a number of years, and they've been working in communication with adult social care teams. And she essentially has presented with periods of distressed behaviour, but largely those periods have been quite time limited, and she's settled quite quickly. Sort of whilst we have had previous referrals open to the team, we had experienced there had been ongoing difficulties in eliciting behavioural change, particularly within the home setting, and so that those difficulties required us to have ongoing communication with adult social care, and where necessary, those concerns were also escalated via the safeguarding process to ensure that her needs were met, and to work as a system. So whilst there were various complexities associated with her case, the key concern really was that the most recent behavioural deterioration was very different to what had been seen before, and the distress had been sustained for a period of in excess of a year, and that really had seen a significant deterioration in her quality of life. So to put that into context, she was no longer leaving the house. You know, before she had been someone who was leaving the house every day, going to day services, spending time with people. But she started to isolate herself within a single room of the house. When carers attempted to support her to complete activities of daily living or to undertake transfers within the house, she became very dysregulated and became increasingly distressed, which resulted in sort of assaultative behaviours to both herself as well as her carers. And in addition to that, her eating and drinking became less regular, and there appeared to be a significant amount of unexplained weight loss. And so really for the MDT, it was necessary to rule out any underlying physical causes which might have triggered these behavioural changes. But there had been ongoing difficulties in the GP being able to carry out some of those physical examinations because she just found that too distressing. So as a result, the CTPLD requested support from myself, and that was largely because I was undertaking this Masters in Advanced Clinical Practice. And as a result of doing that training, I was developing a suite of additional physical examination skills that I would be able to use. So essentially, I went in to start sort of using those. So really, my role initially was to support CTPLD in implementing reasonable adjustments to support the completion of those physical examinations so that we could rule out physical health concerns. The sorts of reasonable adjustments that I used, you know, I work with a team where we've got much lower caseloads, so that affords us the time to see people on multiple occasions if necessary during a day or for much longer periods than you would normally. So I was able to flex according to Cecilia's needs. I was able to visit at different times of day to work out when she was more responsive. I was able to provide much longer or shorter appointments. We also used quite a lot of role play. So what we found was she was much more accepting of physical examinations first thing in the morning before she'd risen for the day, and so she had lots of dollies and teddies. So we started bringing them into the equation and, you know, focusing on doing physical health examinations on them and seeing if she would then be able to help. So it took quite a long time to try and develop her confidence in me and her confidence in what we were wanting to do. And once we'd sort of got into a bit of a routine, we were able then to extend some of those physical examinations on her. Oh, would you like to try listening to your own heart or your own tummy? Things like that. So, but due to the nature of the concerns that we had, you know, there was a need for high level sort of communication and collaboration between and across services at this time. So we were linking in with colleagues at the Royal Berkshire Hospital, adult social care, our own learning disability teams, but also our own physical health teams such as the district nurses. And we were also utilising supports from safeguarding teams and our mental capacity leads. So there was quite a lot of communication taking place at that time. And after a number of months, we were able to sort of rule out serious concerns in terms of physical health. And then we were able to take a much more assertive approach to engage adult social care into reviewing the case and to consider alternative provision to address those quality of life concerns that she was experiencing. Unfortunately, the move away from the home environment occurred unexpectedly, without planning, as a result of safeguarding processes kicking in. But following that, I maintained my contact and I was able to use what I had learnt about Cecilia and use that relationship that we had built to support her in the oncoming transitions within other services. And really what we were able to see was a time that could have been very, very distressing for her, which indeed was distressing for her. We were able to reduce the level of that distress and help her voice be heard. Yeah. So I think, I think overall, from my perspective, it was a really challenging case to be part of. But I think the positive thing is we were able to see some really great changes. So from my perspective, I'm just going to go on to the next slide. We were able to see that Cecilia was no longer self-isolating. While she couldn't tell us what worked for her, we could clearly see that the approaches we had used did work. She now gets out and about. She's had a slow and sustained increase in weight. She engages in health appointments, which previously she had found really quite distressing. And even those more invasive appointments like blood tests, she engages in without concern or distress. And she's been able to build relationships with new peers, or as well as re-establish relationships with significant others. So that was it from my perspective. But what I thought was really important was to reach out to family members and to ask for them to provide their point of view as to how they felt our services had supported their sibling. So the next couple of pages were written by the family. I couldn't think of any whizzy way of doing it on the slide, so I'm afraid I'm just have to read it out to you. But I think it's really quite powerful. So this is from the family, who said, our sister is a young lady with cerebral palsy, a diagnosed learning disability and complex health and communication needs. Just over a year ago, she was referred to RBH for medical review, and subsequently, after 6 months, was relocated to a local care home, identified by the local authority who could care for her ongoing needs. Whilst this transition was necessary, it was also a very vulnerable and anxious time for her, not fully understanding where she was, why, and what her future accommodation and care would be like. Changes in the environment, routines, and unfamiliar staff could have been extremely distressing, particularly for someone who finds it hard to communicate pain, anxiety, or unmet needs. From the very beginning of their involvement, the disability nursing team played a central role in making this transition safe, planned, and person-centred. The team worked closely with the local authority, potential care home staff, family members, and other health professionals to build a detailed understanding of our sister as a person, not just as a diagnosis. They helped hospital staff understand how she communicates, what signs indicate discomfort or distress or illness, and how anxiety presents for her. This means that staff were not guessing or reacting late, but were confident and proactive in supporting her. The LD nurses provided clear guidance around her physical health needs, including monitoring long-term conditions, medication support and escalation plans, specifically supporting her with her mobility and manual handling guidance. They ensured reasonable adjustments were in place so that routine health care, such as GP appointments and reviews, were accessible and meaningful for her, rather than overwhelming or avoided. With the collaborative support of the occupational therapist and the speech and language team, the local health professionals have worked together to facilitate a smooth transition and to enrich our sister's life and future happiness. One of the most important aspects of the combined team's involvement has been consistency. The nursing team acted as a bridge between services, reducing fragmentation and preventing issues from escalating into crises. Because of this, our sister has experienced fewer distressing incidents and a much greater sense of stability in her new home. This has resulted in a cohesive and calm transfer of responsibility to the care home staff. For our sister, this has meant feeling understood, safe and settled. She is calmer, healthier and better supported to live her life in a way that respects her needs and preferences. For us as a family, the nursing team's involvement has brought reassurance and trust. We know that professionals who truly understand learning disability care are advocating for her, supporting the care home staff and ensuring her health needs are not overlooked. In summary, the disability nursing team does far more than provide clinical input. They enable safe transitions, build capability within care settings, and ensure that people with learning disabilities receive care that is compassionate, coordinated, and equitable. From our family's experience, their work has made a profound and lasting difference to our sister's quality of life, which we are deeply grateful for that. So really, I can't do any better than end on that. So I will put it over to you for any questions.
Daisy, thanks ever so much for that presentation. It was a really good insight into the work that you undertake. I'm sure there are going to be questions. Can I open it up, Sally?
Daisy, that was a very inspiring presentation. And I have to say, I've never met an LD nurse before who's doing the advanced practice course, but perhaps that says more about me. But I do know that at a national level, there's a big concern at the moment about the lack of LD nurses, and also the number of people who are training to be LD nurses. And I just wondered if you could say a little bit about how much this care could be replicated, you know, in terms of you've obviously got a lot of expertise, but have you got a full team? Do you have difficulty recruiting given the national shortage?
Not when I mean, we're full with our nurses. We've got 3 learning disability nurses in our team. There have been occasions where we've had mental health nurses, but who have chosen to work in the learning disability field. But it is, you know, it is difficult. And over the years, I've certainly seen fewer and fewer student nurses coming through, and there've been times where it has been really difficult. Yeah. And it is difficult to, you know, you don't see the numbers of people coming through. Yeah.
But you're fully staffed.
We're fully staffed within our team. Yeah.
And you can recruit when you advertise at the moment.
Yes. Yeah. I mean, we haven't, our learning disability nursing posts, we've generally stuck around. So there's out of the 3 of us, there's 1 post that has, that's the one that people have come in and out of. A couple of times, but largely those people have gone on to you know, develop themselves in different roles. So yeah.
Thank you very much. I could ask you lots of questions, but I won't.
Becky.
Thank you.
Yeah, it was just to add to that, Sally, is just to I suppose recognise there is a really significant national shortage, and I think as a trust we've always been quite aware of what's happening at a national level and thinking about how we work to limit the impact of that locally. And so actually we've done some very active work around recruitment recently to ensure that where we know there's gaps ahead, that actually we're recruiting people now in order to kind of mitigate the risks around that. So I think as a trust we're really proactive. So I think, you know, that's a benefit. We are looking at lots of different ways and approaches that we can support people into learning disability nursing as well as a trust, which I think is positive.
Yeah, I don't think, well, I'll talk to you offline. I don't think local universities actually do LD, but never mind.
Thanks, Becky. Julian.
Yeah, so a comment and a question, Mark. Great, thanks, Daisy. It was really helpful to bring to life, I guess, what the team are able to achieve. And with that in mind, maybe more of a question for Becky, which I don't expect a sort of specific answer, but this morning I was on a call hearing a little bit about, you know, the Mental Health Act and the reforms there. And as we know, there is part of that legislation will see a change of admission of people with a learning disability and the detention of people with a learning disability and sort of autism. And the comment was that sort of that will come into play when they think there's sort of sufficient resources to be able to sort of get to that point. And I was wondering whether you thought the intensive support team would be something that we want to start to think about sort of building up. Do you think there is something that's been demonstrated by Daisy, but it's quite intensive work by definition? Do you think if we were to skill and sort of strengthen the team, we would be able to do some of that that's required under the new Act? Or is it something different altogether?
Yes, I think it is, you know, in terms of the work that the intensive support team do, you know, the intensive support team actually came at a point where we reduced our bed base, and we've seen the impact of that in terms of reducing the number of admissions into inpatient services from the 7 years that they've been with us. So yes, I think they definitely are a part of actually the role that we play. The way that we look at it is across all of our services, across CTPLD, IST, and obviously from an inpatient perspective as well, that we all have a part to play in how we prevent those hospital admissions. And I think the other part of that is about actually how we think about it from a system level, Julian, in terms of actually how we strengthen that social care provision in order to kind of prevent the potential risks around admission for people that shouldn't be admitted, and ensure that we're providing that support in people's homes.
Thanks, Becky. Teresa.
Yeah, and sort of linked with that out of hospital provision, we've had some conversations across the Thames Valley around sort of crisis beds, sort of crash pad type provision for individuals with learning disability and autism that would be their sort of a safe place where the IST could support around their care. So yeah, I think there's some opportunities there at system level.
Thank you. Can I just add my thanks to you for your presentation this morning. It was really good to see as well that one of those prime objectives for your team is to reduce hospital admissions. One of the things later on our agenda today is our 5-year draft plan, where we're looking at how we move patients from hospitals into care in their homes or in the community. And so to see a real example being provided to you this morning was really useful. And just one final thing, as well as giving our thanks to you, Daisy, for your presentation this morning, can I please ask that you pass our thanks and appreciation on to the family of the case study that you presented to us this morning? It's really useful and powerful to hear the words of the family and the people that surround patients. And so if you can pass our thanks back to them as well, that'd be greatly appreciated.
Of course,
Thank
I will.
you.
Yeah, lovely. Thank you.
And thank you, Becky, as well.
Thank you. Take care, everybody.
Thank you. Bye-bye. Right, I'll try and leave quietly. Right, bye-bye.
Moving on, we've got quality assurance. Sally, we've had the minutes of the meeting, but would you like to bring to life some of the key points from the meeting?
Yeah, yes, of course, Mark. Colleagues will be able to see there that the committee had a presentation from the head of service and the operation performance manager of from Talking Therapies, and the context was this was a concern from the board in the declining recovery rates and targets. And quite clearly there you'll see that the service has undertaken a wide range of quality initiatives to improve performance and patient outcomes, and it has also focused on staff morale. The recovery rates are improving, but there's a little bit to go there. I won't talk in detail around the quality concerns register because we'll talk about that in detail in part 2. But I think it's important to note that the dynamic nature of the quality concerns register and audiology has been reaccredited and come off. We can see that, and there are some new concerns which we'll probably talk about later. One would be, the pediatric OT, the fact that the waiting lists are over 52 weeks, and also a review of Phoenix House, the inpatient mental health facility, and the fact that bed occupancy is still 97-98% and not decreasing. Perhaps I could draw the board's attention to Martha's Rule, the fact that there's been a very successful implementation there unusually across mental health services, but now also physical health care. And the committee will be looking next time at Jesse's Rule, the implementation of Jesse's Rule. And this is really around out of hours GP surgery, where patients are repeatedly attending and that they're not having a resolution or a diagnosis. We looked in depth there at the Sexual Safety Charter and an update report. Obviously, there's a national concern around that, but locally, we know as a board and as a quality committee that patients are telling us that they don't feel safe. the trust has established a steering group to oversee that work now. Previously, it was led by champions, but this was seen as not robust enough. And it's that group, you will see from the minutes, has got a number of initiatives ongoing and very visible leadership. And we also looked at the Prevention of Future Deaths Regulation 28 reports. If you recall, we'd had 5 PFDRs between June 23 and May 24, and this led to a whole range of initiatives, quality improvement initiatives, not least the implementation of the one team approach. And although that work is still ongoing, the committee agreed that there's no areas where progress has not been made against agreed actions. So in future, that will come back as a verbal report. And then the last thing I'd want to draw to the board's attention is the ongoing work around reducing restrictive practices, and looking particularly at prone restraint, which is used by the police. But the numbers are low, but it's a very important thing to be looking at. And also seclusion review, which is reducing the amount of time patients remain in seclusion, which is now being triggered earlier. But I'm certainly happy to take any questions, Mark, in terms of the minutes of the previous meeting. And Tolo will obviously look at
the 2 following reports.
Yeah.
Any questions for Sally in terms of the Quality Assurance Committee? No? Otherwise, thank you, Sally. That's comprehensive. Tolu, can I ask for your oversight on the Learning from Deaths report?
Okay, in relation to the Learning from Deaths report, obviously we've also picked up on this within the Quality Assurance Committee, but just suffice to say that this report is for Q2, and within that we have had no deaths identified where there was a governance cause for concern. We've had 5 cases where we felt that the care was less than optimal and where there is clear learning across our services. And we have ensured that our services are taking this seriously in terms of the learning, which fits into our mortality and patient safety meetings and learning events. We've also had 8 reviews where patients with a learning disability have died. And all of this, obviously, we refer directly to our Learning from Deaths review, the national leader reviews, and are following that up appropriately. I will take any questions that the committee might have.
Thanks, Tolu. Any questions for Tolu on that report? Sonia?
Yeah, Tolu, I mean, it's just hard to see the word expected death. Can you just talk me through the expected death as a phraseology, I guess? Because, I mean, unless you're palliative care, I appreciate it. It's, a word used, but is that something you could just walk me through a little bit? Because when I see it, how do you define that?
When we talk about expected death, largely, obviously, it refers to patients who are coming to the end of life. So palliative care will be one.
It is.
Now,
Okay.
Generally speaking, there is a phraseology that we use when the question is asked. If you will not be surprised if you hear that somebody dies within 12 months of a particular of a meeting, that in itself is the definition that we use, and often that often applies where there are concerns. So somebody that has a terminal illness, an illness that is so chronic that is coming towards the natural course that we know of. So those kind of things tend to trigger that conversation. And part of that is about how we ensure that people have a good death. What we don't want is people going back and forth from hospital, back and forth from different places of care, when actually what we should be supporting people to do is to live a good life, but also to die a good death. And that process, it helps to support the family. It also helps to support the individual, but ensures that healthcare professionals are providing care that is tailored towards the needs of the individual, making them comfortable.
And Tolu, the only sort of follow, I see only one death I can see this in the year was potentially avoidable. I realised it wasn't this quarter. Do we look year on year, Tolu? Like, have you looked, I know you're new as well, have you looked retrospectively how our trend line is looking on that? And, you know, are we sort of holding stable and positive? It looks very positive when you look at the report, but just wondering, have we got, you know, year on year learnings?
So there is year-on-year learnings. In fact, one of the things that we pick up within our mortality and patient safety review meetings is really for that reason, to ensure that we're not just looking at the present, but that we're also able to take a look back to look at what the learnings has been and whether our trending is going up. In fact, there is an ongoing review at the moment in terms of looking backwards. What are the learning that we've taken from the previous deaths? Has it made any difference? And actually, what are we going to do about it? So there is that piece of work going on at the moment.
I think Sally might have her hand up to assure me that's something you look at the quality meetings. Thank you, Tolu.
Sally, do you want to comment on that?
You're quite right, Sonia. I was just going to say that obviously the governance around this is very robust, in that there are in-depth reviews of this within the Quality Assurance Committee. And what we have here really at the board is a sort of an overview, but just to assure you, yeah, that there's robust governance around this. And then, of course, the governance, Tolu, around the medical examiners as well, which, you know, we were one of the first trusts to take forward, weren't we?
Yes, we are.
Thank you. If there are no other questions, then Tolu, can we move on to the Guardians of Safe Working report?
So again, with the Guardian of Safe Working report, this is a report that covers us up until November of last year, which is the most recent quarter we have reports for. And this is a report that comes to the board to provide assurance that our resident doctors are not working more hours than they should. And we've had 7 exception reports. Effectively, those were where those doctors had to work within 30 minutes beyond their expected closing times, and they were for issues that were beyond their control, emergencies, which you would expect in an acute settings, and for which they have been appropriately, they've had appropriate time off to recompense them for that. We don't expect things, there is nothing that is out of line with what we would expect, and we don't expect any surprises within the next reporting period. I'll take any questions.
That's great. Any questions for Tolu on the report? No, it looked reasonably straightforward for this quarter. Thank you, Tolu.
Okay.
So moving on, Julian, would you like to touch on the highlights of your executive report?
Yeah, thanks, Mark. Yeah, there's quite a bit in it this month. So there's a few items required in terms of national kind of reporting, but there's also sort of at the back end, I'd say a number of items that relate to kind of future kind of strategy. I'm really pleased. I think we should all be pleased, and to thank Tolu and his team for the way in which we've been able to manage the industrial action. I think it's set out quite nicely there. I'd say a couple of things stand out. We've been able to maintain activity. We've been able to safely cover the strikes, but also maintain good relations in terms of kind of workforce and thinking about the, you know, what we need to be doing in the kind of world of tomorrow. I think is helpful, and I'm sure Tolu will be happy to answer any questions. Alex may want to pose something around the Advanced Foundation Trust. One of the reasons why we've got colleagues from NHS England today is, frankly, we're delighted to have been chosen to be, you know, one of the sort of pioneers to go through with this sort of process. And there is a request at the end there, Mark. We just need to sort of check in with Alex on in terms of the self-certification sort of requirements, so we can come back to that. And then again, sticking with sort of our long-term strategy, the Equity Partnership Group involving the local community to keep us frankly honest around our commitment to quality and diversity, and making sure it's kind of, you know, really impactful and outcomes led, I think is a significant development for the trust. But you may, colleagues may have other sort of questions and queries, and we just need to go back to Alex around the Advanced Foundation Trust stuff in a minute. He's beat me to it.
He did. Alex, do you want to pick that up?
Unless there are other questions first, Mark, and come back.
I'm happy that you picked that up. We can come back to general questions on others.
So two things to note in the Advanced Foundation Trust application. Firstly, is the application was submitted last week, and is here in public papers for transparency and also for the board to note that application, and per the board delegation agreed for Mark and Julian to sign on behalf of the board the self-certification statements and approve the final board memorandum. And in public we can see there the full application documentation. So great step. Welcome the NHS England assessment team joining us today. We have our kick-off meeting later and look forward to the assessment process that culminates in our board-to-board with NHS England and DHSC representatives at the end of March, following which panel will make a decision on our application. Any questions on that, please? So the board to note that final application.
Any questions?
Thank you.
I take that as approved then.
Mark, may I follow on to the equity partnership group, because I would just like to build on that, and also perhaps bring Sally in, who kindly chairs this new group for us. We had our first meeting in December, and that was to walk the new equity partners through our current equity strategic work across workforce, patients, communities. It was a really positive session, and there's a lot of ambition and positive energy for these people to support us strategically in our ambitions around improving equity for the population of Berkshire and for our workforce. So Sally, just wondered if you wanted to comment in your role as chair and our connection to the board in this work.
Well, as you know, Alex, when I read the biographies of these independent experts and community leaders, I was very nervous before chairing the committee. But we decided to meet in person for this first meeting, which I think was great because it gave us an opportunity to meet as a group, face to face, in the flesh. As it were. We spent a lot of time for this first meeting introducing ourselves to each other, and also colleagues sharing their area of expertise, their area of lived experience, and as a trust we were able to share some of an overview of the initiatives we're taking forward. But even at that stage, Alex, we got sort of plenty of constructive challenge, didn't we? But I thought it was a good meeting, given that it was the first meeting, and it's clearly going to be something that is going to be invaluable to the trust. So yeah, we're going to meet quarterly and meet the next time in March and build on that. So thank you for the opportunity to chair after I got over my nervousness.
Alex, just a curious question from me. When I read, rather like Sally, when I read through those biographies, I was really impressed in terms of the quality, the experience, etc., of the people that you sourced. Can I just ask, how did we go about sourcing the people to join that panel? Because it really is quite an impressive group that you've got together there.
We went out to national expressions of interest, and I think there's something about the attraction of the work that the organisation is already doing, the credibility we're building, and us being open that actually we need to continue the support and the external support and challenge which this group will give. And I found in doing this equity work with exec colleagues, senior leadership team, that when you bring in that external lived experience or community insight, we can really step forward. So it was a good mutual build actually in terms of the response from those equity partners, and we were very well subscribed in the recruitment and had to select.
It's encouraging to hear. Thank you. Are there any questions generally in terms of the Chief Exec's report and information? Aileen?
Yeah, I was going to ask the same question as you asked, Mark, but then how are we going to integrate that equity partnership group in with our existing network and all the other work that we do in this area?
Sorry, Aileen, I didn't catch that. For me, you were quite muffled then.
I've got a problem with my earphones. Hang on. I asked how we were going to integrate that group with the rest of our network and the rest of the work that we're doing.
With our networks?
Yeah.
Yes, Alex,
Yes.
I think Aileen was asking about the integration of the work of the equity partnership across the other activities that were already underway by the trust.
So we're a mixed group of internal leads and expertise around equity, including our OD and organisation experience and inclusion leads. So people like Carla Innes, Jane Nicholson is a part of the group as well in terms of our workforce. And we have our health inequalities leadership in the group too. So there's an integration through myself and Debbie as executive leads on that group and through our senior leadership team.
Thank you. Sally.
This is a sort of minor point, but in terms of sexual misconduct under reporting, I'm assuming we would also report to professional bodies. I mean, Debbie, you'd expect me to say that in a sense, you know, but it doesn't seem to be there.
Yes, we always have done that, Sally. So the update on there is just the latest asks from NHS England, as opposed to everything we do. So this the board receives 6 monthly the violence reduction paper, which includes sexual safety, everything we're doing towards the sexual safety charter, and obviously the Royal College of Psych standards, which is what we had to the Quality Assurance Committee. But yes, that absolutely, it's one that we would do the referral to the police, to local authority from a safeguarding, and to where they're registrants to the relevant regulatory body.
Right. Thanks for the clarification. Thank you.
Olu, could I just ask a question of you? In your report, you mentioned that we as a trust have maintained good relations with the resident doctors. And I know that team working and cooperation is fundamental to the activities that we undertake. Can I just ask about the relationship that exists between those resident doctors that have taken action and those that have remained in work? Is there any tension? What is the relationship like between those in terms of that cooperation and team working?
So there isn't any tension. I think what we have tried to do is to build some degree of coherence in terms of not adopting a blame culture in terms of the way people work, and it's a choice that individuals have. What we have found, though, is that those who are more likely to have taken strike action are more likely to have been the least experienced colleagues, so the F1 doctors. And of course, because of the timing of the strike, it happened literally within a week or so of them starting with us. So the opportunity to build collegiate relationships and to engage was not really there. So you're more likely to have had more of them. And of course, because they rotate every 4 months, as opposed to other more experienced resident doctors who rotate every 6 months or every year. So there wasn't much of an issue in that sense.
No, it's encouraging to hear. Thank you. Any other questions? No. Otherwise, thank you, Julian. We'll move on to performance now, and Paul with the month 8 finance report.
Thanks, Mark. Can I just check you can hear me? I've been having a few IT issues this morning. Thank you. Good, thank you. So you've got the finance report in the pack, which I assume has been read. I'll just pick up some of the key points. So at the end of November, we had a 1.6 million year-to-date surplus, which was in line with our plan, and we are still forecasting with a degree of confidence that we'll deliver our full year plan of 1.7 million at the end of March. On page 2 of the finance report, you'll see in the summary table that we are actually green and hitting all of our internal financial targets that we've set. Obviously, one of those target 5 is around capital, and we're actually quite materially underspent on capital. So I'll come on to that later in my update. In terms of kind of the key variables and risk on the position, from a workforce perspective, we are still continuing to see our workforce numbers below plan. So both contracted and work numbers fell in month. I think if you looked at the combined factors of tighter workforce controls that we've got in across all divisions in terms of the recruitment panels, which are still holding focus of operational and corporate divisions to deliver the control total, and probably some ability to recruit in some areas. Like I say, we're continuing to see those workforce numbers tracking below plan this year. Combined with that, we're still making good progress in terms of our temporary staffing expenditure. So we've seen a small upward trend over the past quarter, but that's not material. And I think overall year to date doesn't undo the work that's been done. So we are now exceeding both the agency and bank mandated targets by NHSE. So agency spend is now down 32% on this point last year, and bank down 17%. So combined impact of those, both of those, is a £4 million reduction in temporary staffing spend year to date. So if you combine the substantive and the temporary staffing position, we're about 3.1 million underspent on pay year to date. In terms of placement costs, November we managed to hold PICU placements within the 5 that we built into the plan, but we did have 4 out of area placements in November with a net combined pressure of 120,000, which we were able to mitigate partly through the continued underspend on our pay position. It's probably worth flagging early to the board that we are seeing extreme pressure on our mental health inpatient beds at the moment. So we're seeing increased demand. We've seen a number of requests for prison transfers, continuing delayed discharge of clinically fit patients, and we've had some challenges with our physical accommodation being damaged on several instances over the past couple of months. So we are currently seeing a high number of out of area and PICU placements, which I know Teresa and the operational teams are doing their very best to manage in terms of flow. So obviously we'll articulate the impact of that more clearly in next month's financial report. In terms of capital, I'd said we were quite materially underspent, so we're about £5.5 million behind our £9 million plan spend to the end of November. About £1.5 million of that is related to timing on Jubilee Ward, which obviously we approved in principle at the last discursive, and we've got on the agenda for part 2 of this meeting to formally approve. There's £2 million of IT equipment replacement, which again is phasing in terms of plan. So it was expected that orders would be raised in Q3. They've actually just been raised in Q4, so no risk to the overall expenditure. It's just a timing issue. There's 800,000 of leases for 2 facilities, which we're involved with Frimley ICB, so Bracknell Centre for Health and Chalvey Health Centre. These are both ICB new accommodation that's due to come online. So we're dependent on ICB delivering those projects on time to be able to sign the leases as expected in Q4. And then we've probably got combined about £1 million worth of smaller estate schemes across our PFI and other estate, which we expect to complete. So I think overall we're behind plan, but I'm still expecting that we will spend up to our capital allocation by the end of this financial year. The impact of capital slippage is obviously having a positive impact on our cash position. So at the end of November, we had 58 million of cash in the bank, which was 10 million higher than we expected. So as I said, about 5 million of that is due to where we are with the capital programme. And then there was a material timing of cash we received from the ICB to cover some NHSP costs, which we got the cash in November. We don't expect to make the payment to the NHSP until December. So we're holding slightly higher level of cash than expected at the end of November. Happy to hold there, Mark, and take any questions.
Thank you, Paul. And it's encouraging in terms of that state of affairs that you present, again, fairly consistent over previous months. Any questions for Paul in terms of the finance report. Sonia.
Not a question, but I would like to make a comment. Mark, Paul, thank you as always. Concise and comprehensive. How you're so concise and succinct in sharing so much comprehensive information is a credit to you. Also, I'd love to have something to pick as chairing the FIP, but again, the results are phenomenal. To see, Paul, you went so quickly over the fact every single one of those targets is green. I'd really like to take a moment and, Mark, formally congratulate and acknowledge Julian, you and the entire team and all staff. To be green 8 months into an organisation, it is truly, I think, highlights your performance focus to deliver that. I just want to make sure all the board are aware that one of those wasn't green, and we are now all green. So in particular, that's the 30% agency reduction. That is such a challenging target, and I want to again just take a moment of pause to reflect on how you've delivered that and acknowledge that delivery. Paul, so please, my extended thanks to the wider Julian organisation on delivering that. And I wish I had something to pick and a question to ask, but it's more, it's so fantastic that your focus is delivering such great results. Paul, for FIP though, the non-recurrent and recurrent for next year is probably on my mind, right? A lot of that SIP saving, if it's non-recurrent, how do we keep this wonderful performance going is obviously on my mind. But again, that's it from Mark.
Thanks, Sonia. Sally.
Poor old Teresa. I'm going to ask Teresa again, and I always ask her a question about the out of area placements. But Teresa, why are we receiving more requests for prison transfers when we don't have forensic beds and not, we don't have great deal of forensic expertise, do we? Or am I misunderstanding?
No, you're not misunderstanding, Sally. So we've seen a steady increase in requests for prison transfers for assessment. So individuals that are serving sentences that need to come across to a PQ environment for that assessment to be undertaken. And then once complete, be able to either be transferred back to prison to serve their sentence or referrals onto the forensic pathway, which you'll remember is provided by Oxford Health. So,
yes.
So that's part of it. We've seen, I think, probably a growing awareness within prisons around mental health and mental illness within staff there. So I think that is driving some increase. We're not alone. I've been talking with regional colleagues and they've all seen a very similar increase in terms of requests from prisons. So it is a real challenge for us. Once we get a referral from the prison, we have 28 days to secure that bed. So some of that is planned. We've also in the last month seen a couple of instances where it's the end of the sentence and a mental health assessment has happened on the day of release. And therefore you have the same day transfer. So again, drives the need to find a PQ bed if we don't have any capacity locally.
It's a challenge, isn't it, given that we've got such a shortage of PQ beds anyway, and just compounding it.
Yeah, absolutely. That's sort of some PQ is often unplanned demand, but when you have the prison planned work and having to achieve those 28 days, they have to be achieved. Otherwise, there's a concern. And obviously, you put the person who needs mental health treatment at the heart of that. If they're in a prison when they need to be in a hospital setting, being able to provide that transfer in a timely way.
Right. Thanks for the clarification.
Thanks, Sally. Toy.
Because that, just in addition to what Teresa has added, it's a national trend. It also fits into the levels of aggression that we are also seeing within our inpatient estate, and therefore links into some of the things that Paul has actually alluded to. One of the things that we do need to have a think about is actually whether there are changes that need to be happening upstream when people first get into prison in terms of the level, the assessments that can be done in a more planned and proactive way, so that it's not all reactive and last minute. And I think that's a more system approach that we're going to need to have working with partners.
Right. Thank you.
Thanks, Holly. Teresa, just another one for you, probably rather than Paul, that I was going to raise. With the increase in demand for our 24-hour beds. Is the split between voluntary and section patients about the same, or is there a change in terms of that blend of patients coming through?
That there's been an increase in the number of detained patients that we've seen. Those detained under the Mental Health Act has increased over the year, continues to be monitored through the Mental Health Act Oversight Group, just to see if there is any opportunity to have done anything upstream. Mark, again, as Tolu said, could have a detained admission been avoided if there'd been earlier access perhaps to a bed or increased monitoring in the community, but certainly we've seen an increase in detained patients coming across to our inpatient bed stock.
Okay. And where does the work of that group feed into, just for oversight? Does that go into QAC under Sally, or is that reviewed elsewhere?
Yeah, no, it goes into QAC.
Yeah.
Okay, thank you. Tolu, sorry.
So the Mental Health Act Governance Board reviews all of that and then also feeds into QAC, where the assurance goes through.
Okay, thank you for that clarification. Paul, thanks ever so much for the finances. I just echo Sonia's words. We do appreciate the work that you and your team do in terms of the custodians of the finances. I know it's built up from the whole organisation, but in terms of your summary of our position, it is greatly appreciated. Back to you, Teresa, the month 8 performance report.
Lovely, thanks, Mark. So I thought it'd be helpful just to start with the National Oversight Framework. That has been, our position has been republished in the last quarter. So we remain in segment 1. We have dropped down the league table slightly from, we were 3rd in the first publication, we're now down to 9th, but still holding a good and strong position within that framework. So financial position and maintaining that strong oversight is critical to that NOF scoring. So again, the work of the team and our finance colleagues having oversight of that is really important. In terms of some other key metrics within the oversight framework, in terms of the percentage of patients staying over 60 days, 20% of our patients stayed more than 60 days, but that's slightly below the national median, which is 23% of patients staying over 60 days. So whilst there's more opportunity there to look at our length of stay and improve that, against the national picture, we're doing reasonably well. And some other work focusing on our crisis assessments being done within 24 hours and the percentage of those being seen face to face. So there's some work to be done around the pathway for patients and how services are configured, but the biggest opportunity there is about how they are recorded within our system. I don't know if people are familiar, but maybe helpful to know that our crisis team take self-referrals, they take referrals via NHS 111, take referrals from other organisations, as well as referrals from professionals. So improving how those triages are recorded and making sure that we are recording the 24-hour for those patients that need a crisis assessment to make sure that that flows through. That's the work we're doing as a team to improve that. And patients waiting over 52 weeks, 0.29% of our patients were waiting more than 52 weeks, and that compared to the national mean of 0.38. So again, under that national mean for 52-week waits. And that's probably the highlights from the oversight framework. Is there any questions there before I move to our breakthrough objectives? No, okay.
Move on.
Okay, so our main breakthrough objective around our mental health and community hospital is around our length of stay. And we've got a target for adults of 42 days. And in November, that was slightly above target at 46.41 days. So if you every day that we lose is significant, so work to focus on reducing that back down to our 42 days. And our older adult target is 80 days, and we were at 92.57. And if you look at the scorecard, that has been as high as sort of 122 earlier in the year. So some improvement, but still some work to be done there around our older adult length of stay. Our clinically ready for discharge, which is a contributing factor to length of stay. So patients that no longer need to be in a mental health bed. We lost 503 days across adults and older adults. And we have our internal stretch target of 250. So pretty much double what we think is a reasonable level of clinically ready for discharge in our mental health beds. And that was all set against an occupancy rate around 97.7% with our target of 85%. So a really very busy and demanding period for our inpatient wards. And as Paul stated, we've had slightly higher numbers in acute overspill beds for the month 8 position. That has continued through December and into early January. And we're setting up a MAID event, which is sort of a real focus on system discharge flow for the last week in December, first week in February, to see what we can do to bring that back into a more reasonable position. Our community health length of stay is 22.35 days, which is against our ambitious target of 21 days. So slightly over, but they've seen a significant increase in their clinically ready for discharge numbers in month 8, sorry, of 902 against their target of 695. So needing to do some work with our local authority partners, because a majority of those patients require a support package on discharge. So being able to improve flow there. In terms of our quality metrics, in terms of breakthrough, we've seen 93 incidents of assaults against staff against our target of 36, and 30 patients contributed to those 93 incidents. So actually really quite high. We've previously seen lower numbers of individuals. We might have seen high numbers of incidents, but from a lower number of patients. So this is reasonably well spread, and I think goes to that point that we've seen much higher acuity, those prison transfers, the need for PQ, all of those things triangulate, and part of that assaultative behaviour that we've seen on the wards. And our rapid trank, we've had 56 incidents of rapid trank against our target of 39, and 16 patients contributed to that. So some work we've been doing with Tolu, and Debbie's team is doing a bit of a look back around the countermeasures we've had around rapid trank, to see if we can identify what has had a positive impact, what needs to be retired, and any new countermeasures that we need to put in place. The other one I just wanted to bring the board's attention to is the I Want Great Care. So we've seen a dip in satisfaction in October and in month 8, and partly we've seen an increase in response rate, and I know Debbie might want to come in on this. Quite a lot of young people responding as part of their vaccine clinic attendance, and I don't know, Debbie, did you want to come in on that point?
Yeah, it'd be great too. So I think I reported in the November board when we had our patient experience report, the child immunisation vaccine team were really keen to get the experience of the young people that were having those, and they've put a lot of effort in, and as a result got a few thousand responses from young people having vaccines. The impact of that, when I've looked at it, is that young people having vaccines, where they've written comments, are things like they would have liked an injection instead of a nasal spray. They would have liked it to take longer, so they were longer out of class. They would have liked to have biscuits and all sorts of things like that. So when I remove those responses and look at our overall positivity score for all of our other services, which is what we would have historically had, because historically we didn't get that feedback, we sit around 95-96% positivity score, as we always have done. So I don't want the board to feel alarmed that we've suddenly dropped our positivity score across a lot of services. It is a child IMS and VAX phenomenon, is what I would say, and is seen a little bit in December, September to December, when we do a lot of our immunisations and vaccines. I have looked through all of the scores that are less than 3. There is nothing of alarm or concern or anything thematic that we would want to or need to be addressing from a patient safety, quality, expective, or that is within our gift to do anything about. So I just wanted to provide that assurance, really, because it is quite a significant drop, down to 80 and 86% from our usual 94, 95.
Thanks, Debbie. And I think you preempted a lot of questions from us covering that. So thanks for the clarification. Teresa, anything else you wanted to touch on?
Yeah, just the last one I wanted to just is that continued position around our turnover rate. So we've got a very stretched target for the organisation of 10%, and we were sitting at 10.28 for month 8. So that really good stability within the workforce.
Thank you for the report and the update, Teresa. Sally, question.
I wanted to say a couple of things. First of all, I think I'm delighted to see the sustained improvement around perinatal services, because I know that was a concern less than a year ago. So that's good. And Teresa, you know, we have talked around the physical assaults on staff, which is, when you look at the figures, is alarming, really, isn't it? And I know that you've explained it's around it's a small number of patients who are repeatedly physically assaulting staff, and with that also the self-harm. What I wanted to ask was, do you think that the sickness target is realistic, given ours is 5.2 and the national average, and I may have misunderstood this, is 5.10? Is that a realistic target that we've got there now?
About 3.5%.
Yeah.
I mean, I think it's like all things, Sally. As an organisation, we like to have stretch targets, and being able to improve that position down to 3.5 would have a really positive impact on our overall workforce and the continuity of care we were able to provide patients. I think that we've had some conversations as an executive team about whether or not sickness needs to be one of our true north goals, and how do we set the metric, both in terms of the overall number, but also thinking about how we adhere to our policies and processes around sickness management to try and improve that position. There will always be a level of sickness absence, won't there? Because of we're predominantly a workforce that is seeing patients and infections and you know, the levels of sickness that we have post incident and post assault. So there's some areas there that will not change, but I think we may need to have an interim target, but at the moment it's 3.5 as that stretch, noting both our local performance but also the national picture.
Yeah, and I'm also aware mental health trusts tend to have a higher rate as well, don't they? So yeah, I just wanted to raise that, really, looking at what's happened over the last year.
Thanks, Ellie. Sonia.
Just got four points, Teresa. Some we might choose to pick up in FIP, but I wanted to sort of raise them here. I think picking up from Sally's point around, you know, the physical assaults on staff. So it is alarming when you look at it, and unfortunately the upward trend. Teresa, we talked in FIP last time. Are some of these they're not really all mutually exclusive, some of the areas. So how do we overlay some insights around, is it because the number of detainees have gone up and they're more prone to assault staff? Is it, we've discussed before, people are reporting more, which is positive if that's the case. I think, you know, some assurance. My concern on that write-up, it says busy time on wards, so the representation at counter measure review meetings is, and that's being addressed. How do we make sure we relieve staff's time? Because clearly this is not a metric we want to be seeing the going the wrong way. So that's probably the only one I was wondering if you could give a bit of comment on, in terms of how do we get that assurance on people's time to attend discussions around this, I think.
Yeah, absolutely. So we recently held a rapid improvement event, Sonia, and sort of being able to make sure that we are focusing on the key countermeasures. I think one of the things you will see from an inpatient setting, there is potentially a risk of countermeasure fatigue. So we're trying to do multiple interventions across rapid trank, across assaults on staff, self-harm incidents. So actually trying to work out through a review of all of those countermeasures, which ones have had the biggest impact, and how do we perhaps streamline and have countermeasures that may impact on all of those key metrics, rather than maybe 10 or so different countermeasures, because all of them take time to ensure that staff are following. But also alongside that, the monitoring and the oversight of trends linked to that. So I think it may be something to pick up again in FIP in a bit more detail. Right. But how do all those metrics triangulate, and how do we get best bang for our buck in terms of the countermeasures? Because at each assault there is a member of staff at the end of that, and again, in terms of our self-harm incidents and rapid trank, they are often the same patients as well.
Which I think, Teresa, was my sort of second point, which I don't think jumps out necessarily for all the NEDs here. When we look at the rapid trank, I know we've talked about, and I know it's in some of the notes, that the 5 patients are 27 incidents, and there's some cases that can just be, cause those numbers to go up. But again, the alarming trends. I think, Teresa, maybe we just need to think through how we truly get to the bottom of some insights, so we get that assurance that there is the right things in place, and why is it the trends going the wrong way. For me, what is Turbo 10 and reflective learning, just out of interest, because you say that's one of the countermeasures that I've not heard of. So what's that?
Yeah, so Turbo 10 are sort of short, snappy training programs, so often held with an individual. So one of our nurse consultants or one of the clinical leads will go and get a small group or individual staff and talk through what the countermeasure is for a particular intervention, check their understanding. So a recent example has been around sort of reporting of incidents, understanding our staff as reporting, what gets in the way of reporting, do they know how to report? So that could be an example of Turbo 10. And then in terms of reflective practice, there are 2 parts to it. So whenever a patient has been involved in a restraint that included rapid trank, there's a post-incident review with the patient, and we have an external organisation that undertakes those on our behalf, so that the patient has an opportunity to talk through what it felt like for them, and then there's a feedback loop into the clinical team around any learning for staff in terms of how that was experienced from a patient perspective. And then the other part of that is bringing groups of staff together around learning from incidents in that reflective space. So sort of thinking about how we provide psychological safety for staff to be able to explore what went well, what didn't go well, what they've learned, what they might do differently. So that's embedded across all of our teams around learning from incidents.
Well, thank you. And it gets the last point, because we did watch that powerful video, of the individual who didn't want to be trained, but I know you talk about those that do want to be trained, actually that's their preferred method. Yeah. So if there's any way in these reports, Teresa, just to say, of those 16 patients, maybe all 16, that is their preferred treatment. And I think that's just brings a different person-centric approach to these metrics, because I think, yes, behind every assault is a staff member, but behind every trank is a person. Patient. So for me, that's, thank you. But that was key points, Mark. And Teresa will take offline for FIP.
Lovely. Thanks, Sonia.
Thanks, Sonia. And indeed, Teresa, the area of concern, those physical assaults on staff continue to be a concern. Could I leave it for you to liaise with Sonia in terms of what would be appropriate in terms of reporting timescales to have a more of a deep dive and scrutiny of what is happening with all of those initiatives, etc., to bring back to the board via FIP in the future? I'll leave it to the two of you to liaise. Otherwise, thanks ever so much for the report. Moving on to the next item, Green Plan. Paul, and welcome Kate to the meeting. Do you want to give an introduction to this section?
Yeah, I'm happy to Mark, so obviously we approved the refresh of the Trust Green Plan in May last year. So Kate's here to provide a update in terms of what we've said we're going to do, key updates for this year, and I think more excitingly what the plans are for the year ahead in terms of our continued sustainability journey. So happy to hand over to Kate to take us through the presentation.
Lovely. Hi everyone. Thank you for letting me join the meeting today. As Paul said, I'm Kate. I'm the Sustainability Lead Manager. I started in July last year, so I'm relatively new. So I'm just going to give you an update on what's been happening and what this year has got in store. So there's a couple of things I'll go over. You probably are already aware, but the NHS emits about 4 or 5% of the UK's carbon emissions. We're both at the forefront of dealing with the impacts of climate change, as well as significantly contributing to it. So we have a legal and social responsibility to address this. We all know that the events of climate change massively impact health and well-being. This can either be through extreme weather events, it can impact our food supply chains, it can impact obviously the air quality. So we really need to make sure that we are responding to this for our population health. We were the first National Health Service to make a pledge to go net zero back in 2020, and since then many other countries have followed suit, followed our lead in this. We are thought of as world leading in this space, which is really, really exciting, and we've got really clear targets in place to try and make sure that we're achieving net zero. So our initial targets are to go net zero by 2040 for all our direct emissions, so that's the buildings, our waste, our anaesthetic gases, and then 2045 for all our indirect emissions, and they're the emissions that we have an influence over, such as the things we buy. There's a midway target that is very fast approaching, and that is to have an 80% reduction of our carbon emissions by 2032 for all of those direct emissions, and 2039 for all of our indirect emissions. That's from a 1990 baseline, but I'll go through this in a bit more detail later on. There's a number of legislations and mandatory drivers that sit behind all of this as well. That I'm not going to go through all of these in detail, but I just wanted to highlight this. So not only were we the first National Health Service to make a pledge to go net zero, we were the first to put this into legislation through the Health and Care Act. We've got a number of other mandatory drivers, such as the policy procurement notes and the Task Force on Climate-Related Financial Disclosures, which means that we must update on climate change risks and assessments in our annual reports and things like that. There's also a number of legislation or healthcare related legislation and mandatory drivers. There was a Lord Darcy report that I refer to quite a lot that was published in 2024 that I think eloquently puts that the NHS must stick to its net zero ambitions, and that health and climate change are mutually reinforcing goals. So I try and reiterate this message a lot. We're not trying to choose between reducing waiting lists and sustainability or net zero. They will often go hand in hand through things like efficiencies and get it right first time for clinical engagement and things like that. It's also included within the CQC inspections. I know CQC are on this call as well, so we need to make sure that we're updating on any CQC visits under the well-led category about how we're tackling this big project. 2025 was a fairly big year for sustainability. You know, we had the national team and it from Greenham NHS wrote a 5-year forward report. This positively stated that there has been a 68% reduction from NHS England overall since 1990 and a 14% reduction in the last 5 years. It's a really strong message that this is the methodology that they've used to calculate the carbon footprints that we all sort of mirror, represents the most sophisticated and granular carbon footprinting of healthcare to date, and this was internationally recognised as a really strong methodology. We, of course, as Paul mentioned, have published our own green plan in May 2025, just before I arrived, which outlines the next 3 years of actions and targets to make sure that we're on track as well. One of the things that I'm trying to do, and I've started doing, is to also create a number of case studies. I want to really start measuring and analysing the impact of these, fantastic carbon reduction projects that we're doing. And one of those case studies has been about the solar panels that we've installed. So since the installation of those 3 solar sites at London House, Churchill House and Airlie House, we have generated 254 megawatts of electricity, which is massive. And it's estimated to have saved us around £100,000 so far since installation. We do have a target to carry on installing this as well. So our target in the green plan is to do at least 1 more solar installation every year, at least. So how are we doing with our carbon footprint? This is how it's looking at the moment. We've done it from an 18-19 baseline, but we've so far done a 16.7% reduction in carbon emissions so far. We do need to make sure that from an 18-19 baseline, there should be a 47% reduction to meet our midway targets. So we need to do an additional 30% reduction over the next 6 years. I'll go into more detail on that now. So this is what our current projections look like. So you may be aware that there was a project to decarbonise at West Berks Community Hospital that was funded by Salix that the project had to be abandoned due to increased costs and risk. So this has put our midway targets, at risk. We're already reliant on a number of energy efficiency projects to help reduce carbon emissions by 300 tonnes by 2030. We've got a solar farm project currently in the pipeline, which can also do quite significant reductions, but this is at risk due to PPA arrangements being blocked by Treasury. This is something that we're getting independent support on at the moment. So if the solar farm project doesn't go ahead, then we do have a current 186 tonne of CO2e gap that we need to make up in order to reach our midway targets. A carbon proposal paper was taken to the Green Group in December to say how we can manage this. So we do have some plans in place to mitigate these risks, and I'm going to be presenting to Paul and Martin on Friday as they were unable to attend that December meeting. So there's a number of things we can do to make up that gap, and we do have time to do that. So what's been happening, I'm aware of time, so I'll whiz through some of these. I won't go through them all. In terms of progress from this year, we've got a number of things underway. There's been a huge focus on energy efficiency, as we know from the solar, and from other projects. In positive news, we've just been awarded funding. So we've been awarded £245,000 for LED lights and sub-metering at West Berks Community Hospital. These will be implemented by the end of the financial year, and it will do an estimated carbon saving of 80 tonnes a year in terms of energy efficiency. We've also just been awarded £135,000 for a new nature trail and wellbeing garden at Prospect Park Hospital. That's a multi-year project from the Greener Charities Fund, and will begin imminently and should be ready in the next couple of years. That's an exciting project. In terms of energy consumption, this is from the Greener dashboard data. We've had a 28% reduction since the 2019-2020 baseline, which is significant, but as you can see from there, it is sort of tailed out a bit and actually increased slightly over the last year. The big reduction was between 2019 and 2020, where we reduced a number of our estates. So there's lots to be done in terms of efficiency measures. Within travel and transport, we have finalised the travel and transport strategy, which is now out for that final review to be agreed and published imminently. And we've got a clean air plan developed and improved. We're doing a number of EV charging programmes, so we're refreshing our EV charging facilities, we're upgrading at a number of sites, and we've done an analysis to see which sites are most at use and which haven't been so used. And we're refreshing those between this year and next year, we might get funding for it. In terms of business miles are one of our hotspots and often used of what we call grey fleet. So it's our staff's own vehicles, which are harder to influence than our own fleet. But between last year and this year, we've actually increased the number of miles driven by 33,000 miles. And that might be because we're seeing more patients. It might be sort of geographical spread, more face-to-face interaction. However, with the transition to electric vehicles and average prices of petrol and diesel lowering slightly, we've actually decreased our spending on business miles by £243,000 and reduced our carbon emissions by 1.8 tonnes of carbon since last year. So there's lots of work going on to sort of analyse and make sure that we're keeping on track with that. What we don't want to do, I don't want to come in and say no one can see patients face to face because of sustainability. We've got to keep this balance and just try and influence that use of EV vehicles for staff. In terms of waste, we've got a uniform recycling project underway as part of the uniform rollout, and we're making sure that all of our old uniforms are being properly recycled or reused. We've got a good connection between sustainability and IPC to start implementing reusable products within clinical settings. A big achievement this year is that we stopped sending any waste to landfill, which has avoided approximately 18 tonnes of carbon every year. And we're increasing the rates of recycling year on year. We've got various targets for clinical waste to reduce incineration, which is a really high carbon and high cost form of getting rid of waste. And we've almost reached that. We're actually a little bit under the incineration, which is good. And communication and engagement. So we have developed our Net Zero Heroes group, and I'm reaching out to a lot of clinical teams to do 1-hour CPD sessions with them on sustainability. We've got a really strong comms plan for next year. I'm organising a number of travel events across our key sites, and we're getting newsletters sent out quarterly, and also making sure that we get those case studies sent to national team. So actions for next year as a summary, again, I'm going to try and skim over these slightly, but we've got the travel and transport strategy almost ready to go. And as I've just said, we're going to organise a number of travel events at those large sites. I want to create and implement multi-year energy and decarbonisation projects, specifically at those bigger sites, and implement energy efficiency initiatives to bring down that energy demand. We want to expand and upgrade the EV charging facilities. I've already mentioned about the installation of more solar panels, and we want to really try and see if we can get that solar farm at West Berks over the line. We've got a target to deliver board level training for this year as well as appoint a clinical lead to support with the clinical elements of sustainability and work on that nature trail. Overall, what do we need to do in that bigger picture? We need to reduce our greenhouse gas emissions by 47% by 2032. That's a huge target and will involve the phasing out of fossil fuel heating if we're going to make it. So we need to have a solid plan in place with trust backing to say that this is happening and we are phasing out the fossil fuels. We obviously need to reduce water and waste and focus on our second biggest hotspot, which is travel. So from this year, from the end of this year, all the vehicles offered through the NHS Salary Sacrifice Scheme will be zero emission, and all of our new owned and leased vehicles from next year will all be zero emission as well. And as we go, this is a phased approach within sort of moving to EV. We need to make sure the infrastructure is there for our staff as well. And then it's all about the Design for Life roadmap from the government. It's all about the items that we buy and making sure that any single-use med tech products are part of the circularity system, and we're not just disposing of things unnecessarily. So that was everything on my presentation. Thank you for listening. Are there any questions?
Hey, thanks ever so much for that presentation. It felt a real tour de force in terms of covering so much ground, and I appreciate the speed with which you went through it. Sonia, question.
Well, welcome, Kate. I know I've asked Paul and Alex lots of questions on sustainability, and they keep saying you're coming. So it's fabulous to have you,
Thank you.
on board, and great to have a subject matter expert. So that clearly came through, both your passion, knowledge, and understanding in such a quick space of time. I'd like to acknowledge that. It is also great to see in the deck scope 1, scope 2, scope 3 reference. I know I pushed on wanting to see that at a recent board meeting, so I'm glad to see we're now able to identify that. And fantastic, we've got a 3-year plan, a comms and engagement plan. So Kate, the actions you've got, I'd like to acknowledge those. Question just for clarity. On slide 178, you've got the 16.7 reduction. Is that scope 1 or was that scope 1, scope 2, scope 3? We've got a 16.7% reduction over that period in the headline. Is that total reduction?
That would be scope 1 and
that
2.
Was
Sorry,
one.
Scope 1 and 2.
And 2. Okay.
Yeah.
So just for clarity. And then when you said by 2032, you got 80% decrease in direct, so that's just scope 1, and then 47% overall. Is that scope 1, scope 2, and scope 3, or what?
Sorry, that was a bit confusing. We refer to both of these sort of midway targets. So it's an 80% reduction from a 1990 baseline, or a 47% reduction from a 1990. Sorry, from a 2019-2020 baseline. They're both the same midway
so
targets.
Which baseline?
It's just a different baseline that we're using.
So very good. Then I did hear, obviously, you want to have some support to phase out fossil fuel. And my thoughts went, Paul, CapEx. I assume you're going to need CapEx or OpEx to do that. That's not minor. I assume we're yet to figure out what kind of numbers that would cost us, because we all want to save the planet. We all want to make sure we drive sustainability, but it comes clearly at a price. I assume we don't have any of that ready yet. I mean, that's where indicatively can only by principles align with what we've set our targets towards, but the practicalities and pragmatism sometimes clearly kick in. So Kate, I don't know if we've looked at that, or Alex or Paul.
Sorry, Paul, you go.
So we've got there's a general view, isn't there, which is we're taking advantage where we can of national funding to be able to make some of these initiatives for real. Kate's done a brilliant job, even in the last couple of months, responding to national funding that's become available at very short notice to get a couple of £100,000 worth of funding into the organisation to accelerate LED. And I think it was meterage as well, wasn't it, to put some increased monitoring in place. So we're taking advantage where we can. Big schemes like the decarbonisation of West Berks will be absolutely key to achieving these targets, but we know that in some cases it's not just as simple as actually getting our hands on the money. Some of these are really difficult to deliver because of the nature of some of the buildings we're trying to put them into. So it's clear, outside of travel, the two biggest opportunities we've got to hit these targets are the decarbonisation of West Berks and decarbonisation of PPH, both of which are PFI provided facilities, which come with significant complexities to try and get these schemes delivered in. So it could be that there may be, I take the interim targets in place, but some of these may be challenging to deliver within the timescales whilst we're still within the PFI agreements. But it's something we will continue to work on with the PFI providers. They're aware of our targets. They work with us where they can to make sure we can implement some of these green initiatives. But like I say, some of the bigger ones around decarbonisation are going to be quite challenging.
And I think I love the graph, right? I love your forecast graph versus target. I think that clear articulation, Paul and Kate, to us, to the non-exec directors, to just stipulate and really highlight. You won't make this happen without A, the funding, and B, the infrastructure challenges operationally are huge, right? So certainly appreciate it. But what a wonderful presentation, Kate, and thank you.
Thanks, Sonia. Yeah, I'd also like to just mention that the PSDS funding for decarbonisation has stopped. So that was sort of multi-million-pound project funding that we could get to decarbonise that isn't available from the government anymore. So what one of my plans is for this year is to really identify what boilers we have where, when they're due for renewal, so we can get that high level overview and we're not just reacting quite suddenly to, oh, we need to get these boilers replaced ASAP. We can only do this with gas boilers, so we're not replacing like for like, and we've got an actual strategy and plan in place to replace them with non-fossil fuel heating.
Thank you. Aileen.
In case my headphones aren't working, I've put my question in the box. Can you hear me?
Yeah.
We can.
Yeah. So first of all, well done. Secondly, I was just really interested about the nature trail and garden at PPH, just to hear a little bit more about that. I know we're definitely a bit first and fast. And then finally, how are staff engaging, particularly if it means that they are having to perhaps take not an easy mode of transport to help us, but perhaps the most challenging, difficult one. Overall, how are staff?
Absolutely.
Kind of two questions, really.
Yeah, so the Nature Trail and Wellbeing Garden at PPH was a second round of applications for it, so I picked it up from my predecessor Justine. The engagement has gone for the application with staff members at PPH to help us with that application to make sure it's as clinically informed as it could be, and was really about rehabilitation for patients being able to, when they first get leave, for it to be meaningful and not just go to the sort of local shops. So that's a multi-year project. So the first 6 months are going to be about procuring a landscaper and engagement with staff and patients on what they want there. I've got ideas of sort of sensory gardens and 6 different elements and a quiet zone, but we have to have patient and staff engagement with this. To make sure that it's as meaningful as possible. So we've got, and it's a multi-year project, so we've got time to do this justice, and we've got collaborators with BBOUT, who are Buckinghamshire, Berkshire and Oxfordshire Wildlife Trust. So we're getting all the special sort of expertise there to make sure it will be as successful as possible, which is great. I'm happy to send you more details if you'd like to see them. And then with staff engagement, it's some staff members are engaged, I think some aren't. So this is why I'm trying to do these travel events. We're linking with local authorities on these events as well, so that we can really start highlighting and incentivizing sort of safe and lovely cycle routes to work, for example. I think we do have a challenge in the sense we've got a large geographical area that isn't very well connected with public transport. So staff members who are going out to patients all day, it's just not practical for them to be using public transport, and I'm not blind to that. But for certain staff members coming into work and having the same commute every day, they might be interested in just giving it a go, and I think we've really got to work on engagement for that.
Super. Thanks ever so much, Kate. That's been really informative and extremely useful in terms of bringing us up to speed with your work. And it would be useful to have regular updates at the board as well in terms of how that progresses. So I'll leave that between Paul and Julie to organise. But otherwise, thanks ever so much.
Thanks for having me.
Thank you. Moving on to, but it's quite timely, our neighbourhood health presentation. I believe that Layla and Deepa are with us already. So Teresa, do you want to give an introduction to this?
Yeah, thanks, Mark. So we've got some colleagues joining us from our community health division who have been focusing on what neighbourhood health would look like and building on what's already in place as we deal with the challenge of the left shift as part of the 10-year plan. So I'm going to hand over to Claire, who will introduce her colleagues. We've got some clinical colleagues, but some of our ops colleagues in case the different questions come up. Claire.
Thanks, Teresa, and morning all. Nice to meet you. I don't think I've met many of the non-execs before, so nice to put some kind of faces to the names. So I'm Claire Williams, and I'm the Divisional Director for Community Health Services across Berkshire, and joined today by Dr. Layla, who's our consultant geriatrician and the lead for this work. Also joined by Deepa, who's our consultant nurse lead, and Dorcas is here, who's one of our lead matrons for multidisciplinary work. So this kind of journey probably started about 18 months ago. So we spent a lot of time talking about it, and really it was about access to community services, and actually how tricky it is to access community services. So that's where the project started, and you'll hear from Layla and Deepa outlining that problem and what we want to do to simplify access to community services. And then probably latterly, as you'll have heard, the neighbourhood agenda has come down nationally. So we've really started to think, What does that mean for how we organise our services so that, and the impact that will have possibly on our structures and how we organise ourselves in neighbourhoods, but more importantly as well, the impact on patient care if we organise ourselves under a neighbourhood rather than possibly what we've got now is a bit of fragmentation and silo implementation in our care. So Leila and Adipa are going to take you through. We've got some slides. I am aware of time, so we will try and take that within about 10 minutes. Is that all right, Mark, in terms of for your timing?
Yep, if we could stick to that, that would be useful, because I'm sure there's going to be plenty of questions at the end.
Perfect. Okay, Leila and Deepa, thank you very much. Can I hand over to yourselves?
Thank you. Do we share the presentation, Claire, or?
Yes, please, Deepa.
Sorry, please let me know if we can see.
Yeah.
We can see it, Deepa.
Okay, so you just need to put it on. Yeah, perfect. Hi, everybody. So I'm just going to talk to you about our vision for neighbourhood health. And I'm going to, oh, can I DP? Right, perfect. We know that as a system, we're all under pressure. So primary care, secondary care, ambulance services, community service, we're all struggling. We know that we have an aging population. We know that there's increased demand. We know that there's pressure on everybody to deliver good care, and we do our best. And with the whole left shift, we're trying to kind of move care into the community. And we just need to be thinking about how can we do this? How can we just move with the trend and improve what we're delivering? Can we move side? So within BHFT itself, we offer multiple community services. We offer lots of community nursing services. We've got our hospital at home. We've got we have our mental health services. And it can be a challenge. Like I said, the clinicians in primary secondary care are struggling. And when they're wanting to refer in, we have an excellent single point of access system, but it's administrative led. It's not a clinical triage. So the person who's referring in will need to know what they're referring to, which adds to a bit of frustration and can make that experience not as great as it should be. So they might be referring in for one thing, but actually their patient needs lots of things, and they're just not realizing what they need and what services we can provide for them. Also, the way that our system is working is that we have to keep referring into individual services. Yes, we have a single point of access, so one phone number to each everything, but we have to have multiple calls to those multiple services. So it's not ideal. And then what happens is it causes frustration. It can hamper relationships between services. Also, what is currently happening is patients are being referred to one service and it realizes actually this is not the right fit. It gets declined. It then delays the patient receiving that perfect care. We also know that there is some inequity within Berkshire. We know that in Slough and Reading that patients not attending their appointments. We haven't really got some good safety net to improve that. So our vision is really to help move with this left shift, moving hospital care out into the community. Start to think about it's costly, it's time inefficient to be managing crisis. So we need to be thinking about, yes, have something to manage crisis, but think about prevention as well. We need to be starting to think about digital solutions to deliver better care. We do have it, but we can do better. And we need to start working as a neighbourhood, working as a community, rather than silo organisations. And even within our own organisation, rather than working with silo services, we need to be thinking about us as a community working for our residents, our patients. Next slide. So what is a neighbourhood? It's a community. It's a community for our patients. As I said, it's health services working alongside social care, voluntary sector, working for our patients seamlessly so that we're not duplicating work, which at the moment we are. and also to empower our patients, let them, so that they feel that they're getting seamless care rather than, oh, so-and-so's coming today. I'm not sure if I've been referred to this. Actually, we're all one. Next slide. Sorry, there's a bit of duplication. So what could a neighbourhood look like? Like I said, we work as a community rather than silo working, bringing that care closer to home, reducing the pressure on ambulance services, reducing the pressure on hospital, trying to keep people well at home. Having a single community team. This is going to be a challenge, but I think it's a challenge we can work towards. Having a single plan, so it's being visible. So at the moment, we do have a challenge. We work from different IT within BHFT. We work from one IT system, primary care, another IT system. So we need to start using what we've got available, connected care, but also now start to have shared care documents on a system which we can all see. Oh, sorry. Okay. So how are we going to deliver this? So try and bring, first of all, start with a clinical triage system. So rather than having an administrative single point of access, have a clinical triage system where the referrer comes in, phones, talks about the problem, then the expert down the phone will say, well, actually, these are the services I think our patient needs, and we'll do the referral onto all of those services. So one call, one lot of information, one form for all services. This hopefully will improve experience for the referrer, will improve experience for the patient, will also improve experiences for us, the experience for our staff, so that they're not bouncing, we're all working as one. And it helps distribute the resources. How can we can start introducing, we already have MDTs, but let's get a neighbourhood MDT where we have community matrons, get them more aligned with our primary care, get our voluntary sector, all our services in one. Start thinking, we already do some case finding, but do a bit more case finding, utilising the data that's available to us, picking up on using frailty scores, using PGNs to pick off those people that are at risk of deteriorating and starting to proactively work with them, get them to recognise their health conditions, get them to recognise their numbers, get them to recognise when to seek help and how to seek help when they do deteriorate. Have a single care plan. Our integrated neighbourhood intermediate care, there'll be once again, the clinical triage system. So if the patient is at crisis, refer to the hospital at home team, they manage the crisis. They then, if the patient has rehabilitation needs, we will then refer onto either our domiciliary rehab, where our teams go out to them and deliver rehabilitation, or we can use our community beds for inpatient rehabilitation. But also, they don't have to reach an absolute crisis. They don't have to be within our hospital at home team. They could be primary care using our clinical triage, saying this so-and-so is deteriorating, they're needing more help. And they can then direct them to the right rehabilitation service. So thinking about our patients. Next slide.
Thank you, Lila.
I'm going to hand over to Deepa, who's going to give you a case of where we can actually show how neighbourhood works.
Thank you, Lila. So this is just to put it into perspective what we are currently doing and how we can enhance the care that we are providing to our patients even better by having a neighbourhood team. So I'm going to use a real case example. So Mrs. Smith, she was a 79-year-old living with her son who was doing night shifts, but providing informal care support to her during the daytime. That includes preparing meals, shopping, cleaning, and everything, supporting her emotionally as well. So she was managing okay. She was independent, mobilizing with a stick at home, had some underlying health issues, chronic health issues. She had a rectal cancer and had oncology treatment, and cancer was stable. Due to her age and degenerative changes, she does suffer from a chronic back pain, and she does get a recurrent urinary tract infections. But she was managing independently. So, and then over a couple of weeks period, she was gradually declining, and her mobility got deteriorated a little bit further, and she had 2 falls. Legs gave away when she was walking, and that exacerbated her pain. and the son was getting more stressed to manage her during the daytime and also working in the nighttime. He contacted the ambulance following the second fall. Luckily, she didn't sustain any injuries, but care stress was very prominent, and the SCARS team, ambulance team, referred to our hospital at home service to assess her at home to see if we can keep her out of hospital and provide the support she needs in the community. When the hospital at home team went to see her, she's definitely, her mobility has declined and pain was a dominating factor. Need optimizing her pain medications, and also we needed to give some break for the carer as well for her son, so that she gets the support that she needed appropriately in the community. So the team discussed community inpatient admission for a rehab where she can get a more therapy support, and also we can optimize her pain medications. And also the team started her on antibiotic to cover her oral and urinary and chest infections at the same time. And also the team had discussions around her escalation plan, resuscitation status, and if she does become unwell, how we can support her in the community rather than sending her to the hospital. So they had that discussion. Patient was transferred to the inpatient community hospital where she had a nearly 10 days inpatient stay for a rehab. Her mobility did improve, but she normally with this cohort of people, they need a bit longer to recover from that episode when they have some underlying infections or when they have a fall to build up their confidence. So the inpatient team discharged her home with the community support from the intermediate care team with the therapy support, and also she needed district nurses input to manage her pressure areas. And also because of her weight loss, she was referred to the dietitian as well. So overall, she did receive a good care. Her mobility did improve, but we do know she needed further rehab at home, which was arranged. Since she was discharged, multiple services were involved and they were all doing their bit. But there was no like a coordinated support for her. For example, if she does family or she needs some support, who they can reach out to, individual key contact, that was missing. So also the therapy team noticed when she was mobilizing more, she was getting a bit more pain. Her pain medications needed further optimizing, and she developed a further infection which needed addressing as well. So they were reaching out to the GP. So what we could have done with the neighborhood, having the neighborhood is more of a coordinated joint up care for her. Where these things we could have picked up to how she's managing at home after discharge through having a key contact for the families. So through community matrons, monitoring how she is doing it, optimizing her medications where needed. And also if she does become unwell, rather than sending her to acute, how we can escalate that within our services to hospital at home service to do that, provide that ongoing joined up care and support for her. And also when she had a fall, she was referred to a hospital at home service and also falls clinic at the same time. So like Leila said, it is a single referral. So the referrer gives the information, what is currently happening, and the neighborhood team can decide what services are appropriate for them. So they don't have to make a multiple referral. And also what we do know with this patient is she did have over the last 1 year period, 13 contacts with the GP surgeries. So we could have done some proactive work with her to identify where the risks of to reduce that crisis situation happening, providing that bit more proactive support. Like we said, there are MDT work happening in certain areas where with the neighborhood approach, we are making it that more standardizing, implementing that best practice across to all patients to provide that equitable service. And also carer support as well, working very closely with the voluntary organizations and primary care, and referring to the social prescribers or doing that carer assessment to see how we can best support them to keep that patient out of the hospital. So with the neighborhood, we will have a bit more joined up working, continuity of care, more patient-centered approach, providing that holistic care, and also, like Leila said, more around looking at shared care plans. So information is accessed by all services involved rather than reducing that duplications. and also digital respect plan where it will be available through connected care where everybody can see in real time rather than reducing that administrative task, sending separately to the ambulance team or GP once we have updated. So overall, it would be a positive outcome for the patient. We are providing good care. We can enhance that even better and provide that continuity and see how patients are doing when they have a little bit of dip with the infections and when they are treated, how they are recovering, so that we reduce further risk of admitting them to the hospital. So we can do that. What it would look like in the future, more easier access to care, making it a bit more simpler, fairer access for everyone, care based on their need, urgency, rather than looking at the criteria or waiting times, making best of the use of all the services involved, knowing what is happening at individual services through neighborhood. We'll have an oversight of what their individual team capacity is, who is best available to support the patients at that given time, and making sure that follow-up care continues so that we do a good work during the reactive time, but more focusing on what is happening and doing more proactive MDT working. So we pick up things early rather than waiting. So more focus on the prevention rather than reacting or reducing that crisis situation happening, and working more closely with the local services, our acute partners, primary care, voluntary sectors, and local authorities. Whereas with this patient, we could have picked up that and provided the arranged the care a little bit earlier to avoid that crisis happening. Any questions?
Can I just say thanks to all of you in terms of that presentation? It really gives quite a positive view of the future in terms of how care could be organised. Rebecca, question?
Yeah, echoing what Mark said, thank you for the presentation. I had two questions. The first one, earlier in the presentation, you talked about there being more missed appointments in Slough and Reading and needing to look at that. I was just wondering if you had any insights at this stage as to what is leading to those appointments being missed.
We're just starting on that work, Rebecca, but we've got some really kind of great data that really show our residents of Slough and Reading have significantly higher do not attend rates than our other kind of neighbourhoods. So, and some of that is kind of is cultural. It is kind of that kind of not. Some of it is kind of health literacy, kind of, you know, we've looked at, so dietetics, for example, have actually found they had significant DNA rates in Slough, and actually just changed the wording of their letter so that it was more reader friendly to some of those local populations. So work to do, but it's actually quite significant. So a heart function team have literally, for the population again in Slough, found that they should be seeing a lot more higher proportion of Asian patients. So actually they weren't, so took a bus into the town centre, and actually it was daughters bringing fathers in to get their health check. So it's just challenging some of the kind of cultural barriers that we see in those areas in particular, where we've got the greatest kind of deprivation alongside that as well. But fascinating it'll be for us.
Yeah, thank you, Claire. And the second question was just in terms of the new move towards the neighbourhood care. I think there was mention in the presentation about supporting carers as well. I'm just wondering whether you signpost for any respite for carers. I'm just conscious in that case study you're talking about this gentleman working nights but then caring during the day. So I'm just thinking when is he sleeping and resting as part of that wider neighbourhood connecting with other partners and services?
I mean,
Yeah,
oh, go on. Sorry, Deepa, go on.
So by doing a proactive approach, so we can predict, we can identify these earlier on, and then working with the local authorities to see how best we can support them, and also signposting the carers as well, what other resources they can access or reach out to. So increasing that would help, working closely with the voluntary organizations and with the local authorities, social services for respite care, or arranging the care a little bit earlier. rather than waiting for the crisis to happen, situation to happen.
Thank you, Diva. Sally.
If I've understood it correctly, Claire, we're interpreting neighbourhood health as integration or working together with voluntary sector, social care, third sector. Can I ask you what the governance would be around that, or how we're developing the governance around that?
We are developing the governance around that, Sally, as we speak. So certainly we're looking at organising ourselves more in neighbourhoods, geography of neighbourhoods, but actually at the moment the team is very much health focused, but how we bring, as you say, more social care, housing, the voluntary sector into that. And certainly within the across Berkshire, we're looking at setting up some integration leads who will help us understand and work through that governance, because as you say, we are many organisations with many different kind of digital systems, so a puzzle that we need to kind of work through and unravel together. But yes, we have to get it right.
So at the moment it's more health focused, but the idea is to
broader,
evolve and then bring the governance in as later.
It'll go at the same time. We'll have to agree the governance arrangements as we bring more people into the team and work together in a neighbourhood.
Right. Thank you very much.
Thank you, Sally. Julian.
Yeah, thanks for the presentation. Just thinking about, again, a future sort of world. So Layla, you talked about, how we currently receive referrals. So, when I'm out and about and I speak to primary care leaders, they're positive about Berkshire Healthcare and everything, but the multiple referrals for community services in particular sort of drives them sort of mad. And what you described was a simplified system. So, a GP may have a query, quite not sure how to deal with it, but thinks our services might be able to deal with it. In future, clinician at the other end might be able to point them in the right direction. I think that will go down really well. I think it'll be the question I guess we've got to think about, and I don't expect an answer today, is in terms of our strategy, the resourcing of that. Because if you think about what you described, this conditions, greater frailty, where you've got much better segmentation of the population, so we kind of know where the demand is. We're on a block contract with a fixed amount of kind of staffing, really. So as we make it easier to access and potentially do even greater preventative work, one of the things we're going to have to be really clear about is not frustrating people by saying we're at capacity. We could provide this service, but guess what? There's only space for sort of 10 folks. So I think there's something about us thinking about, in terms of our strategy, what level of resource we'll need in order to fund what national policy describes as the left shift. But also, Layla, that I think the give and the get with the primary care is how we share some of the resources that are currently sit in primary care and our services, rather than them operating in silos and duplicating. Does that make sense to you as a clinician, Layla?
It absolutely does, and that's the importance of these neighbourhood MDTs. It's where it's not just BHFT sitting around the table. It's all organisations sitting around the table talking about their resident, talking about how we deliver care best. And you're right, I think it's going to be trial and error around who's responsible for what, but we do get there. I mean, with the hospital at home, it's been a very up and down journey, and there will be times where we will take more things which aren't our criteria to support the system. We do that already, and vice versa. When we're struggling, the whole point is about sharing resources, about working together to deliver the best care for the person at the right time. So if they're calmer, if they're quieter, they pick up some of the slack. We work together to deliver the best care, if that makes sense.
It does. Can I just say a big thank you to all of the team? I can see that this is still in its early formative stage, but the objectives that you set are so aligned with the 10-year plan and what is being set for all organisations. So it's great to see a tangible example taking place of how we're learning to progress down that route. So thank you to all of those who have presented, but also if you can extend our thanks to the rest of the team that are doing this pioneering work with you. It is much appreciated. Thank you. Moving on, Trust Seal. Paul, is there anything that you need to add to the document, or is that just there for noting?
It's there just for noting, Mark. It's integral to RBH's expansion of diagnostic facilities at the site, so we'd be fully supportive.
Okay, that's great. Thank you. Next item is the Council of Governors update. Just a couple of things that I wanted to report there. A survey has been issued to all of the governors to assess their views on the activities. The timing of this is really ideal in terms of us having a new chair coming on board from the 1st of February. The closing date for that survey is the 23rd of January, so we'll be pulling together the results of that and feeding it through both to the Council of Governors and also to Francis as the chair to see how that can be improved in terms of moving forward. We had a meeting with Brian Wilson last week, which was joined by Julie and Jenny, where Brian was just raising a concern in terms of how governors can be afforded more opportunities to meet with patients, their families, and conduct visits, etc. And it's something that he's taking to the membership meeting in a couple of weeks' time, which I'm attending. The reason for mentioning it now is if I could just ask, particularly the non-execs, if you are intending to undertake a 15-step visit or service visit, could you consider contacting Jenny or Julia just to let them know that if one of the governors wanted to attend with you, it'd afford them the opportunity firsthand just to have that insight into the service and potentially meet some patients, which I know is easier on the community side than on the mental health side. And finally, from me on this subject, I just wanted to formally note my thanks and the board's thanks to Brian as lead governor and the Appointments and Remuneration Committee of the Council of Governors in terms of the amount of work and effort that they put into the recruitment exercise for the new chair. They really did pull out all the stops in terms of attending meetings, conducting reviews, etc., and conducting interviews. And so I just wanted to formally thank them. I think we achieved a lot, or they achieved a lot in fairly short order, and we've ended up with a very good result from that. So if we could just formally minute that, I'd be very grateful. The final thing was any other business. I don't believe there isn't. Is there any other business? Julian?
Just a very quick one, Mark, so thank you in terms of your sort of last board in the interim role. Obviously, Martin stepped down in sort of June to go over to Hampshire, and just all on behalf of the board and the organisation, thanks as sort of deputy. I don't know whether, you know, when you are appointed a deputy chair, you ever expect a sort of 6-month stint, but on behalf of all of us, thanks, Mark, for stepping in and allowing such a smooth transition between Martin and Francis. So I just want to acknowledge that sort of publicly and say a huge thanks, Mark. And it's not as if it's been a quiet period for you either. So double thanks on that note. Cheers.
Thank you, Julian. That's much appreciated. As I've been saying to everyone else, normal service will be resumed on the 1st of February. The date of our next public board meeting is on the 10th of March. And now, if we can consider a resolution to exclude the press and public from the remainder of the meeting, as publicity would be prejudicial to the public interest. It's coming up to 9:15. Can I suggest that we close this meeting now and that we